the curb cut phenomenon, right? If you build a society that cares about people who have the toughest challenges, you often end up solving for problems for everybody.
Like a lot of the schools that have moved away from phonetics and more of a dyslexia-based treatment or education for all, it benefits students at large.
Hello and welcome to Neural Compass. I'm your host, Mark Jacobstein. Very excited today to be talking to Dr. Deb Houry. Dr. Houry is both an MD and a PhD, or an MPH, I should say, and her work in public health is a lot of what we're going to be talking about today. She's the former chief medical officer of the CDC, still currently an emergency physician and public health leader, a member of the National Academy of Medicine. Really extraordinary background, I think, largely in terms of thinking about the things that cause the most harm and injury to Americans and how to prevent them. And that has taken a lot of different forms in the course of her career. So in any case, really excited to have you today. Welcome.
My pleasure. Great to be here with you.
So Deb, maybe I thought the first thing we could talk about today would just be the path. So what is it? I'm always curious, MDs go through an extraordinary amount of training between your residency and medical school, not to mention undergrad. You're already starting your career sort of a decade after the rest of your peers. You throw an MPH in there on top of it. Sort of, what was the path? How did you get interested in public health specifically, and how did that come about?
Well, interestingly, the MPH didn't add any time. When I went to Tulane, they had a combined degree program, and I didn't think at the time what it would mean to add an extra degree on a medical degree. So I did it within 4 years. But, all joking aside, it was actually really helpful to be learning about individual patients as well as populations at the same time. So for me, I didn't know any different. My training was both, in the classroom and with patients with that clinical and public health perspective from the beginning.
So with it, that sort of clinical and public health perspective, obviously you started your career with, among many other things, obviously pulled into work for the Obama administration during the Obama administration during the heart of the opioid crisis. Talk to me about what it was like, how you got pulled in, and some of the policy changes that you thought were most important that you were able to implement.
Yeah, and before I even got to CDC, I was an ER doc, so I was seeing really the evolution of what happened with the opioid epidemic, really from the front lines, so starting with the prescription opioids and then, moving into some of the illicit opioids like heroin. When I got to CDC, I tried to maintain my clinical practice, but ended up as an MAT or medication-assisted treatment provider during that time. So I was still, taking care of patients. The injury center, which I was leading at CDC, was among the first to kind of sound the alarm for these unintentional overdoses and looking at the data. And so we quickly began to scale up a national program to really work with states to collect better data on what was driving the overdose, to work with hospitals around better prescribing, as well as distribution of naloxone. And I led through my team, the opioid prescribing guideline for chronic pain.
You and I have talked about this a little bit before, but I think the opioid prescribing guideline itself was quite important. There's a podcast I listened to years ago, Malcolm Gladwell, describing the differences between some of the opioid prescribing rates in various states and how, in part, those were driven by what seemed like small policy changes, like whether or not writing a script required you to sort of write it in triplicate and one copy was going to end up in, say, the State House in Sacramento in California or not, and the sort of extra friction that was introduced by some of these things, and also the sort of oversight that was introduced, changed the prescribing rates. And you could look at states with very similar demographics that would have extremely different profiles in opioid use. Like, I think as I recall, Massachusetts had a huge problem. New Jersey did not, even though the two states actually look very similar. And anyways, one of the things that they'd unpacked was that the ways in which prescribing happened had a huge impact. So first of all, I'm curious, this being Malcolm Gladwell, always interesting, I'm always slightly skeptical. Was that an accurate reading of some of the things that happened? And was that related in any way to some of the changes that you made in terms of the way people were supposed to write scripts?
Yeah, well, I'm never going to argue with Malcolm Gladwell, and so I'd say, I think he was right on to something. I also really like Sam Quinones, the book he did, Dreamland, where he really talked around some of the changes in communities and the pill mills that led to this. And early in the epidemic, it was driven by prescription opioids, including some of the overprescribing. And both length of prescription as well as the dose of the prescribing. And so people that were on high dose opioids to start versus starting at a lower dose would become more physically dependent and potentially go on to be addicted. Similarly, if you go in for tooth pain or an ankle sprain and you got a 30-day prescription versus a 5-day, some people think it's like an antibiotic, and take the full course. And again, you can become physically dependent. When I was in the ER, I would print out a prescription that I actually have to change the default setting to less days. And so I think when you're looking at systems like that, you can't really hold the doctors at fault when you're looking at like what the computer is printing out, or the smart sets, what they are doing. And also, back in the day, there were pain scores, and pain was considered a fifth vital sign, and patient satisfaction was around that too. And so there was an encouragement to really prescribe pain medications, including opioids. Certainly, as the science showed that they were addictive.
Sorry to interrupt. I want to there's an interesting point embedded in there. It's just sort of like the power of incentives, right? And it's just like if the incentive for the hospital is to have high patient sat ratings, which what could be wrong with that? We want satisfied patients. Well, actually, what could be wrong with that is but one way to keep people satisfied is to manage their pain in ways that are great in the short term and poor in the long term. There's probably an essay to be written about how much of pathological human behavior is related to short-term gain at long-term loss. But that feels like it was probably more important than people realized at the time.
I think so. And also pain is, very complex, and first of all, it's subjective. A number 8 score for you might be different than for me. And, although you could give a super strong pain medication to lower it immediately, it might be saying, you have a fracture. We're going to treat you with a strong pain medication for a few days, but we also are going to need you to look at, longer term physical therapy or non-opioid. And I think, that's a longer conversation, and that's making sure patients have access to all these different modalities. And that wasn't always the case. So if you're talking about patient satisfaction in 2 minutes to do an action, prescribing an opioid was easier.
That all makes sense, and extraordinary to see sort of what it all led to. I mean, I guess there is some good news over the course of the last couple of years. Maybe we have crested a peak here in terms of the opioid epidemic. I was lucky enough to speak to Keith Humphreys just a few weeks ago, and at least his perspective on this. And curious if yours concurs, is that there's a variety of factors at play in terms of the reduction in the opioid deaths over the course of the last couple of years. And then actually, for better or for worse, perhaps the most important is the precursors from China that are being used to make the fentanyl now are not as strong or not as dangerous as they happened to be 3 or 4 years ago. And so that's part of it. But also some of the things that you worked on with widely available naloxone, et cetera. And so maybe with the benefit of hindsight, how do you feel about some of the interventions that were implemented? Are there things you would change now even if we are sort of crested a peak, we still have a very serious opioid crisis in the United States that is very different, frankly, than the rest of the developed world. And I'm curious, if you were still running the CDC, how you would think about what would be the right interventions?
Well, it's interesting because it continues to evolve. So, went from the prescription opioids to heroin, then to fentanyl. And what was so dangerous about fentanyl is it just took a few granules. And you're right, by, some of the restrictions on precursors and preventing it from coming into the country, that did impact it, but so did access to treatment. We still know people aren't getting the access to treatment that they need, and naloxone has certainly played a role. But now we're seeing polysubstance where people, are using methamphetamine, cocaine, a whole mix of drugs. And so that makes it more difficult to treat because you're not treating a substance, you're treating multiple substances. And for, people who have issues with opioids, there is a medical treatment for it, with medication-assisted treatment and things like buprenorphine. With stimulants, there's not a great treatment. Sometimes you can do things called contingency management, but the treatments are very different. And so I think we also have to look at starting earlier. And, one of the things I was interested in when I was at CDC was preventing people from using in the first place. And some of that even goes back to preventing childhood trauma or looking at childhood trauma and, linking people to the right resources through therapy and behavioral treatment, even just acknowledging it and treating underlying medical and psychological disorders. That would also help, lessen substance use. I'm worried, although the numbers are going down. There's a couple of states that now started to report an uptick again. And so my concern was, when there were recent changes by this administration around things around risk reduction, like syringe exchange programs, fentanyl test strips, that we might start to see an uptick. I thought it was too soon to take our foot off the gas pedal, that we still have too many deaths in this nation.
Yeah, it's interesting. And I suspect that some of the multifactorial pieces you're talking about are also related to sort of different epidemics in the U.S. that are different but related. So suicide and loneliness, two that I think about a lot. Obviously, at Jiminy, we spent a lot of time thinking about overall like individual mental health and then social mental health, and it feels like the lack of social connectivity that people have is certainly related. Interestingly, I mean, in this conversation I had with Keith, one of the things he talked about was the difference between the experiments with drug legalization in Portugal and say in Portland. And one of the things he pointed out was that because of the tight social bonds that you have in a place like Portugal, drug legalization it still came with like drugs were still there was still social stigma and tight social connections. And so legalization was a thing that could work in a way that it can't if you're in a society where the bonds are not as tight. I know you've done a lot of work on thinking about both loneliness and suicidality, and I'm curious to get your perspective now. I mean, in the what I think of as like the age of anxiety and how that's all playing out, and maybe a public health perspective on what might work.
I do think there is a lot that can work. And I think we have to look both at the individual, but also communities. And I think you were really onto something when you're talking about loneliness. Certainly during COVID, we saw isolation, really exacerbated a lot of these conditions. Some people are pointing to technology, but I always say technology is here. And so it's like, how do you utilize it to help? And there's been groups that have looked at like older adults and having connectedness that way. If you're in rural areas, you can have access to treatment or, again, different social groups that way. So I think it's how do you incorporate technology to really decrease loneliness? Certainly, even if you're in like a hybrid workplace, I know people like to come in person because there is still something that can't be replaced about those in-person connections. But how do you use technology really as an adjunct to that? And then you can look at community-based interventions. So looking at things like whether it's, safe storage to peer counseling to looking at people that might be at risk. There's programs called like Sources of Strength that really look at community-based programs overall to work on building like resilience, building really what I consider like the supports, the protective factors, because if you can strengthen that mitigates different risk factors. And then certainly you can look at the individual level. What are the risk factors? Is there a family history of mental health? What does the individual have, like prior mental health or substance use issues, childhood trauma? Identifying early and getting help. And often people think, asking about it might precipitate, mental health issue, but actually makes people feel better that somebody cares about them and wants to get them help. And so certainly, 988 was introduced a few years ago, and that was a way for people to access mental health services wherever they are. So I think really speaking more about mental health, destigmatizing it, normalizing different ways to get therapy, to build connectedness is really important. And I think I talk about like the building blocks, they need to be outside running around, but they also need to be establishing those social connections and fostering that.
Yeah, well, it's one of the many reasons I'm a big fan of, say, team sports for kids. It's just a great way it solves so many different problems all at once. As a father of a 10-year-old, I think about that a lot. But I go back, I mean, it's interesting because I think some of what you're talking about exists as sort of like the individual treatment and at the intersection of what a therapist might do or a social worker or primary care physician, kind of thinking about the health of the individual. And hopefully also sort of social change as it relates to destigmatization of mental health challenges and people being willing to talk about loneliness, et cetera. I'm curious about your thoughts in regards to like, what's the government's role in all that? It is a public health crisis if there's a lot of loneliness and suicidality, and maybe the loneliness leads to mental health challenges, which leads to opioid disorders, et cetera. But how do you think about as I say, like, what's the role of the government to impact that? What are the most effective interventions?
So, interestingly, like in the UK, they put a leader in charge of it to really focus on things around loneliness and social isolation. I think, here, I'd say federal government's role is really around research, to continue to support research around, what are some of the precursors of mental illness? How can we prevent them? How can you look at different ways for connectedness and certainly studying that? Funding some of the early childhood programs is really important, to lessen the trauma that children face and make sure they are able to build the resilience so they don't have the long-term consequences. And then funding treatment, through agencies like the Substance Abuse Mental Health Services Administration are really important. I think that's really the role of federal government. Some of the work I was funded early in my career through NIH was in the emergency department. If somebody came after a trauma, we would do exposure therapy to really prevent, long-term development of post-traumatic stress disorder. But that was through NIH funding, and so you do need that funding to look at novel treatments as well as implementation. So federal government has a role in this for sure.
Yeah, it's interesting. We had a conversation with Tom Insel on this show just a few weeks ago. Tom was the longtime director, of course, of the National Institute of Mental Health, so the branch of the NIH that covers mental health. And he pulled an amazing statistic for us in terms of like the number of grants that have been written in 2026, as of May or June, whenever this show was shot, was a small fraction of in 2026 of what it had been even in 2025 for the NIMH. So we know that there's been a drying up of funds for sort of federally sponsored research for mental health. The social programs, I think, are also really interesting and important. I mean, I joke, it's not a joke when I think about public health is like, we just need more pickleball. The social connectivity component feels incredibly important to me, and also one that may be complex in terms of like the role, again, the role of government versus just hopefully these things happen in society. Maybe switching gears, of course, you left the CDC, you have some new projects now. I'd love to hear you sort of talk about those, and also how you think about the future of public health in the age of AI, advanced biomarkers. There's a lot of exciting things happening with technology. Technology, definitely a sharp double-edged sword that may be causing some of the problems that we have. We can talk about that too. But so maybe we'll start with like, what are you working on these days, and how are you thinking about the future of public health?
Yeah. So, after I left CDC, I wanted to still have, that impact in communities. So I'm working with many different state health departments as well as some non-governmental organizations really on how can you innovate and have impact, looking at things on data sharing across states, lab prioritization, but then also how can you use like data and community signals to respond with better messaging and to understand more what's going on in the local communities to be responsive. And that's not meant to replace, federal government or CDC, but I think of the whole continuum of public health from a local community to state to a region to federal. And so really looking at, other aspects of public health. And then I'm working with a couple health tech companies because technology is here. So how do we use that to really extend care for patients? And one group I'm working with, Akita, is doing a lot of great work with street medicine. And that's a hard to reach population, and that allows physicians to take on more patients, like up to 500, because they can have a caseworker or somebody in the field using AI technology to help with really that kind of patient intake. And they've been able to use that for medication-assisted treatment as well to do a lot more remote and then bringing a provider in. So I think technology can certainly help with the hard-to-reach populations. And then I love what y'all are doing at Gemini, when you look at the clinician in the loop, because people are worried about technology replacing people. I think when you're looking at medicine, it can help. And so it can really look at between sessions, how are you able to augment care, through whether it's videos or behavior prompts. So I think this will really be a benefit to public health when you look at technology on how you can extend care to harder to reach populations, keep people engaged. And then when I was at CDC, our data, we were working on incorporating new data streams. And I think this is where AI and technology can really be helpful, looking for different signals from different sources to predict things much earlier.
So say more about, you mentioned street health, and it's not a
Yes.
term I'm familiar with. What's the definition of street health?
So this group is really looking at unhoused populations. So, people that don't have a regular place to stay. And so it's literally meeting people where they are at and then providing to care to people, on the street because they're not, going to their primary care physician on a regular basis and much harder to reach. And many of them have chronic health and chronic mental health conditions. And so a really at-risk population.
And it sounds like part of the solution here is not just sort of having the social will to try to help these unhoused populations, but also the use of technology to kind of extend the reach of the healthcare system. So that somebody who's, for example, not an MD can have access to MD level information because of like an AI assistant, and it allows them, they're not going to write a script, but they can certainly have sort of more intelligent advice or interventions that they can provide sort of on the spot. Is that the idea?
Very much so. And, and even, if you are an MD, using AI to really help with your differential diagnoses, did you consider these other things? Oh, yes. Thank you for that reminder.
I
So
mean, I don't know.
I
It's funny. I listened to my wife have this conversation. My wife's an MD in genetics, and I listened to her speaking to some of her peers recently. Like if you're not using open evidence and you're not using the latest, like why on earth not? It's extraordinary how helpful they can be. There was just a piece. Actually, be great to get the authors of this on here. There's just a piece in the New England Journal of Medicine in the last week where essentially, I think it was some docs from Boston Children's in conjunction with the team from OpenAI did some analysis of hundreds, perhaps thousands of children who'd had genetic testing and had some sort of genetic disorder. And they were able to ex post facto re-diagnose or successfully diagnosed 18 or 19 of them when they had not been able to originally. And that the model, OpenAI, was not making the final diagnosis. A doctor from Boston Children's was, but the hypothesis generation was developed using sort of combination of advanced omics and the ML and what the LLM knows, and pulling in information from the EMR and doing things that frankly no human had been able to do because it was too complex or the information was in different and fragmented places. And I do think hopefully that's sort of the future of medicine, is like the AI augmented future.
I agree. I think that's where it's really useful. I just read a book last week called Primal Intelligence, and it reminded me of, why we need humans still. Yeah, that humans won't be replaced by AI and everything. And, what makes us unique and different from AI and LLM is emotion, intuition, and really looking for those exceptions, not focusing as much on logic and synthesis of data. But the book even looked at like special operations and like why were some so successful? And it's because they would look at what was the exception, and then they wouldn't be thinking about what they had done previously. It was how do you get to that next level, and using their intuition and sometimes being guided by emotion, gut, and literally common sense. And I think that's where being a clinician, still having hands on the patient, seeing what is going on, and that spidey sense can't be replaced.
Yeah, no, I think that's right. And the way I think about this is sort of the Jablon's paradox piece of like the technology will make it easier and less expensive to have access to more medicine that is not going to decrease our need for medicine. In fact, it's going to, like, there's almost limitless need for health and thriving, and it will hopefully open up new channels for that. Maybe switching gears here a little bit, I know I heard you in a recent conversation talking about sort of AI and new biomarkers and the implications there as well. I'm curious how you're thinking about that, and is that sort of a public health area you're pulling on as well?
Yeah, I think, when you look at the ability for AI to synthesize and do modeling, so whether it's, biomarkers or like even a molecular compound for something like, tuberculosis drug or what hasn't been considered, when you're looking at a cancer treatment, AI can take like thousands of potentials and narrow it down to a smaller amount that then could be studied, in clinical trials. And I think that's what's exciting, is it can open up the potential and maybe, raise some, biomarkers that hadn't been considered before. And also really looking at putting multiple things together, switching gear like slightly as I'm just thinking, like autism. We know there's so many different, it's multifactorial. So, can we use AI to look at, what are the different input with medical records and other things or environmental exposures to start to narrow in more on, what are some of the more like common etiologies for it?
Etiologies and probably also treatments. I mean, I think this is the other thing is
Very
I
much
could think
so.
about autism spectrum disorder and other neurodivergent populations that have challenges living in the world that is as the way it is constructed today for folks who are neuronormative. And I suspect sometimes that like there are relatively small changes we could make that would make that would be better for neurodivergent populations, would probably be better for everybody else. Like minor digression here, I have a colleague I work very closely with who spends a lot of time talking about the curb cut phenomenon, right? So we figured out that it was a good idea to cut curbs so that it was easier for folks in wheelchairs to get up onto the curbs. And it turned out it was really useful for anybody pushing a stroller or anybody bringing home the groceries or anybody who's, over 70 has got a cane, or for little kids. And that one of the really interesting positive effects from a public health perspective of like, if you build a society that cares about people who have the toughest challenges, you often end up solving for problems for everybody. Like cut curbs are useful. It turns out they're good. They're probably going to be useful for the robots delivering groceries too. So my suspicion is
Dyslexia and like Orton Gillingham, like you look at that too. Like a lot of the schools that have moved away from phonetics and more of a dyslexia-based treatment or education for all, it benefits students at large.
or even fonts that are easier for
Yes.
kids with dyslexia to read turn out to be actually a little bit easier for everybody to read, which is
Yeah.
something as I move into deeply into middle age here, I get more and more conscious of the fact that menus apparently are all written by people in their 20s who can read 6-point font in low light, and it never occurs to them that might not actually be something for those of us who are no longer in our 20s. I digress. So hopefully this isn't too political a question. You had a really interesting perch inside the CDC for a long time, and the CDC has a very particular mandate. You're out of government now, so I mean, I guess you
Yes.
help with some local governments, but you're out of federal government now, so you have no restrictions. If you were thinking about like from a public health perspective, I mean, forget CDC in particular, but just sort of like how would you structure, like you get to wave a magic wand, all of a sudden you're emperor. How do you think about public health as like what would you want to set up? What would the priorities be? And this can be sort of a meta question. How do I set this up inside of a democracy, but also like a practical question, like I'd have a lot more focus on automobile deaths and gun violence than we actually currently do, because it takes away a whole lot more qualities than cancer, which kills people who are in their 80s or whatever. Like, how would you think about this?
I think I'd look at it from, two lenses. One, like you pointed out, like what are the leading causes, of death and morbidity, and certainly focusing on that, but then also always being prepared. I think we have to look at like what could be the next pandemic or what should be the next health threat. So not losing track of that. So I think you balance the prevention along with the readiness to detecting health threats that continue to innovate around vaccines, new therapeutics. But I also think, it could be done, with more decentralization, looking at giving, more to local and state health departments. You need a federal presence though. I always think now that should be the floor and not the ceiling, and that innovation and really building out should come from that, but shouldn't be driven by it. And so I think we need a federal health system that really is providing, data across the nation. States and locals can then determine at what granular level they want it, helping with that integration. Certainly providing funding for research when it comes to a lot of these different, diseases and pathogens. Providing funding to health departments is still really critical. I do think, though, actually having more people in the health departments and communities, kind of like that back and forth between federal government and being in communities, is really important. So you've got stronger relationships, much more of that bi-directional engagement would be important, particularly if you're looking at responses. And then looking at ways to use technology more, as, we see these opportunities, like how can you use technology to extend public health in communities to listen more to communities through some of these signals. But I think you still need that federal presence when it comes to data, preparedness, and some of the leading causes of death.
I think the preparedness piece is incredibly interesting. And one, I think about the doomsday scenarios. I mean, I work in AI, right? So I can't not be thinking about bioweapons and asymmetrical threats and sort of how scary it is when the bad guys have access to like super powered, super intelligent synthetic biology. But I spend less time probably than I should thinking about how to prevent it. So actually, I'm curious, like, how do you think about that? Like, what's the role of the federal government? I mean, obviously, we did a really good job of spinning up a vaccine very, very quickly when COVID happened. I don't know how much credit to give to the federal government. I give a whole lot more credit, frankly, to the folks who'd been working with mRNA for a long time and understood how to characterize a spike protein really quickly, et cetera. But how do we get ready for these potentially asymmetrical threats?
I think you have to do it on a couple of fronts. And one is you have to actually be looking for it. So whether it's things like sequencing, so you can understand, okay, this sounds like a scary pathogen, but actually it's not that virulent or it's not that transmissible. Okay, we can keep that in a box over here. This one doesn't sound so bad, but actually it's super transmissible. We need to focus more on how do we prevent it. So whether it's through sequencing or wastewater data, even different types of, social media scanning, to see what treatments people are now, taking or what symptoms, there are like different, syndromic clusters from emergency departments. Like what are these new clusters and being able to detect it quickly, then being able to know what interventions are needed. Is it the mRNA vaccine? I do want to give President Trump credit though. Operation Warp Speed, that could have failed, but by it very much worked. And so by, putting a lot of funding out there, realizing you might only have a couple of candidates that work, it was important to do. And so I think, being ready to do that, and then testing continued therapeutics. We're learning a lot more about immunotherapy, gene therapy. There's all these different things that are out there. And then the bread and butter, you look at antibiotics. We're continuously, increasing antibiotic resistance. And so what do we need to continue to look at from new treatments in that standpoint too? Should there be some super bug that then we need to treat? So I think it's detecting it, being able to respond to it, and then being able to treat it that we can't lose sight of.
The detecting piece is very interesting too. I mean, I know like, Google knows an awful lot about what's happening with public health just based on like who's searching on flu symptoms, right, at any given time. And presumably Anthropic and OpenAI do as well. And there's massive signal to be found there. But you made this point earlier, like testing wastewater, like there's all kinds of ways to be testing. And I realize that there are privacy advocates who get upset about that. Although when it's done at a population scale, I just, at least personally, don't actually see like the privacy risk relative to the social gain of actually understanding what's happening. Like, oh, look, there's a novel pathogen that's terribly virulent that has just appeared. Like, it seems like something we should know and outweighs any privacy risk. But it's a complex question potentially, but interesting to see how this all evolves over time. So, Deb, this is fascinating. I thank you so much for the time today. I'm going to close with the final question here that I have for all of our guests. Neural Compass is for folks who are interested in sort of mental behavioral health, what's happening with neurobiology and AI, and kind of the intersection of the three. And this takes us into lots of different places, including things like public policy and public health. I'm always curious for our guests, things that they are reading, watching, listening to that are related in some way to the themes that we have here on Neural Compass. Now, you mentioned a couple books, which probably bears repeating for the audience, but also anything else that you viewed recently or listened to, et cetera, that you think would be really interesting for the audience.
I'd say probably just the two I mentioned, like Dreamland is a much older book now, but that really just talks about some of the opioid epidemic origins. And then Primal Intelligence, for me, really got me thinking about, how do we differentiate what a human can do versus AI? And what are ways you can actually strengthen your own, I think he called it like superpowers. Like, how do you strengthen, that your own intuition as well? And so those are the two that I would probably leave you with.
I love that. And actually, I have not read Primal Intelligence. I would like to read it both with the lens of understanding, at least from the author's perspective, what it is about our intelligence that is particularly human. It's also interesting to think about as the AIs get more advanced. And one of the many things we want to do is teach them empathy. And actually, it appears that not necessarily that hard to do. The ways that we can make powerful AI as human as possible, at least in the ways we want it to be human. Humans are, we're good with the empathy.
Yes.
We're also, there's,
Positive traits.
yeah, as a species, we're we're reasonably flawed too. We've been hitting each other with clubs and sticks for as long as there's been humans too. So maybe we'll keep some of it, train out some of it. Anyways, I will add primal intelligence to the list. I really appreciate the time today, Deb. Thanks again, and we'll have the episode out soon.
Sounds great. Thanks so much for having me.
The thing I keep coming back to from this conversation is Deb's point that we've been so focused on reacting to crises, we've forgotten that prevention is where the real leverage is. Whether it's overdoses or loneliness or the next pandemic, if you can stop it before it starts, everything gets easier. In this next episode, I'm sitting down with Dr. Nisha Mack-Gulliby, a clinical psychologist and professor at Harvard Medical School, who's doing some of the most exciting work I've encountered on what's actually driving depression in a subset of patients. It may have a lot more to do with your immune system than your childhood. If Deb gave us the population view, Nisha gives us the biological one. Neural Compass is brought to you by Jiminy Health. To find out more about Jiminy Health and how our clinical-grade AI solutions are helping to shape the future of behavioral health, visit jiminihealth.com. And then make sure to search for Neural Compass in Apple Podcasts, Spotify, or anywhere else your podcasts are found. Make sure to click subscribe so you don't miss any future episodes. And on behalf of the team here at Jiminy, thanks for listening.